Thank you and good afternoon. And thank you so much to the people who have spoken to us today. I think hearing these comments is very important for all of us. And I'm really appreciative that you recognize what a difficult decision we are undertaking and how much complexity there is to the problem. So thank you very much. Today, I'd like to introduce the session initially by thanking our work group. We have a really robust work group that's done a great deal of work recently, as you're aware. Particularly, I'd like to thank Art Reingold, Jeff Duchin, Ali Kemp, and Lori Rubin, who are the members of the committee who sit on the work group. But also, I'd particularly like to thank Tamara Pilishvili, who I think is here somewhere, and Sarah. Oh, there she is. And Sarah Tomczyk, who has done a lot of the work for this analysis, so we're very appreciative. Just to remind you of the terms of reference, and I'm not going to read through all of these, but I think the most important one on this slide is the last, which says revise or update recommendations for pneumococcal vaccine use as needed. And that's really the source of the discussion that we're going to have today, is the question of whether or not new evidence has come to light that we need to take into consideration in deciding on vaccine schedules. In particular, we are addressing the routine infant immunization schedule for 13-valent pneumococcal conjugate vaccine. And as was mentioned, we did discuss this at our last meeting. The committee requested that we do some further analyses and bring this information back to the committee. So that's what we're going to do today. But first, I'd just like to set the context for this discussion. As you know, there's been evidence supporting the use of a 3-dose schedule emerging throughout the world. There is a 3-dose schedule used and approved by the European Medicines Agency. The WHO also recognizes a 3-dose schedule as an alternative to a 4-dose schedule, and in many low-income countries, that schedule has been implemented. In addition, at least 21 high and 13 upper middle-income countries have also introduced PCV13 or PCV10 as a 3-dose schedule, or they've switched from a 4-dose schedule to a 3-dose schedule. So it's important to recognize that we are seeing increasing evidence of the value of a 3-dose schedule throughout the world. The second issue that is very important to us is the perception that the vaccine schedule for children, and particularly infants, has become very crowded. And there are some safety concerns over simultaneous injections being given. We're concerned that this may lead an increasing number of parents to delay or refuse the recommended vaccines. So essentially, we want to be certain that every vaccine we're giving to a child is needed. There have been some rare safety issues associated with co-administration of routine vaccines, and this committee has heard reports on each one of those issues. The third issue that has really driven us to consider this change is that PCV7 has led to such huge reductions in pneumococcal disease in the United States, and in pneumonia in children and adults, and in otitis media in children. The PCV7 serotypes have virtually been eliminated from all age groups, a remarkable, remarkable accomplishment. And now we're watching as disease due to the PCV13 serotypes is also reducing quickly. So we've seen a huge reduction in disease burden in the United States. We now have a mature program using PCV. So the question has arisen, can a 3-dose schedule be included for the routine schedule for infants? Will it be safe? Will it be effective? How will we approach this change if we are to make it? We hope today to provide more information about this question. However, we are not going to make any specific recommendations today. We're going to review the GRADE evidence, and we're going to address some of the questions that were raised in the October meeting. We also will discuss some considerations for including a 3-dose schedule for infants. Some of the questions that we have for the committee are, is the evidence adequate to consider including a 3-dose schedule? And if not, what additional data or information would be required? So this is the agenda for today's meeting, for today's session. Matt Moore will give us an update on the direct and indirect effects and also the vaccine effectiveness studies. Sarah Tomczyk will discuss the grade review of evidence that the work group has been working on since our last meeting. And Tamara Pilishvili will discuss considerations for a reduced schedule for children. So with that, Tamara? Matt? Right, Matt.
Thank you very much, Dr. Bennett, and thanks very much to the committee for your interest. I'm going to be relatively brief today because most of what I have to show you is a continuation of trends and information that you've seen before. But at the points where there's something truly new to share with you, I'll make a concerted effort to point those things out to you. So this is, again, just a reminder. You've seen a slide like this before. We monitor invasive pneumococcal disease using active population-based and laboratory-based surveillance in 10 areas around the United States. This is called the Active Bacterial Core Surveillance, or ABCs program. It's part of the Emerging Infections Program at CDC. We have evaluated rates of invasive pneumococcal disease over time, and after the introduction of the 13-valent vaccine, we have focused primarily on the impact of that vaccine on 5 additional serotypes. And we focus on those 5 additional serotypes because we know that the 7-valent vaccine included an antigen against serotype 6b, but that antigen actually has activity or cross-protection against a serotype that's not included in the vaccine, and that's 6a. 6a is also included in the 13-valent vaccine, so if you take away those 8 serotypes that are affected by PCV7, you're left with these 5. We've also been evaluating for evidence of the emergence of serotype replacement. This is what happens initially at the level of the nasopharynx when children are vaccinated with pneumococcal conjugate vaccines. Those vaccines eliminate carriage of vaccine types and they're replaced by non-vaccine types. And then with the PCV7 experience, what we saw over time was that some of those non-PCV7 types began to cause invasive disease. And we've been monitoring for a similar sort of effect after PCV13 introduction. And then finally, I'm just going to give you a very brief update on individual level vaccine effectiveness from our case control project. So this is a slide showing you annual trends in invasive pneumococcal disease among children under the age of 5. I apologize that these lines are in color, but your handouts are not in color. So let me orient you to the first one because they're all formatted exactly the same way. The line at the very top in purple represents all invasive pneumococcal disease, so all of the serotypes that cause invasive pneumococcal disease in kids under 5. And then this red line here are those additional serotypes that are uniquely affected by PCV13. The blue line here represents those serotypes that are not in PCV13. And then finally, this green line way down at the bottom are those serotypes that were affected by the 7-valent vaccine and are continuing to be affected by the 13-valent vaccine. So what we see from this figure is a big reduction in those additional serotypes caused by or included in the 13-valent vaccine, and that's what's driving this overall reduction in invasive disease shown in the purple line. So now that I've oriented you to that for kids under 5, let me show you what's happening in adults 18 to 49. Because we don't think there's been much uptake of 13-valent vaccine in adults, and especially not in this age group, we think that probably most of what we're seeing here is a reduction related to use in children and the prevention of transmission of those vaccine types from children to adults. And so again, if we focus on the red line right here, it was kind of flat for several years and then began declining after the 13-valent vaccine was introduced for children. Again, these are the 7-valent types down here and the non-vaccine types remaining pretty flat in that age group. When we look at the 50 to 64-year-olds, the picture is slightly different, but only slightly. These are those additional serotypes in PCV13 in the red line, declining after vaccine introduction in 2010. And we begin to see perhaps the suggestion of an increase in these non-vaccine types, those types that are not in the 13-valent vaccine in that particular age group. And a similar sort of pattern in adults 65 and over. Nice reduction in those additional types in the 13-valent vaccine, and perhaps a suggestion of an increase. So when we use our modeling approach to estimating percent changes in disease in each of these age groups, this is what we see. And this is a bit complicated, but you have all of the numbers in front of you. Let me just point out the general pattern. The general pattern is that we see the largest reductions in the first year of vaccine introduction. We see the largest reductions in kids under the age of 5. And then those reductions are lower for the unvaccinated populations, again, through this herd protection effect. So as you go down in each column, the pattern is the same. Very large reductions in the youngest age groups, and then smaller reductions in the older age groups. If you go across the table, what you see is that each successive year, the reductions are bigger than the previous years. And so what this is showing you is that with each successive year of use of PCV13 in children, we're continuing to see reductions in those vaccine types or those additional types affected by PCV13. So this is all very, very good news. With respect to those non-PCV13 types that I mentioned, it's really just this one age group, and really just in 1 year, in 50 to 64-year-olds, there is this small and statistically significant increase in non-vaccine types in that particular age group. It's not present in any of the other age groups. And when we combine all of these data together, so the residual effects on the 7-valent types, the renewed, or rather the new effects on the additional types in PCV13, even after accounting for this small increase, and we look at the changes in all IPD, we are still moving in the right direction. That is to say that in each of these age groups, there are primarily statistically significant reductions, especially as we get into the latter years in the older age groups. And so if that is a little bit of evidence of serotype replacement in the 50 to 64-year-olds, it is not overshadowing the continued reductions that we're seeing in those serotypes that are included in PCV13. We've also, so this is an update now, these are new data. Last time I was here and we talked about effects through June of 2012. We mentioned that we estimate about 20,000 cases had been prevented through June of 2012. This is now an additional year of data, and we believe it's up to about 30,000 cases prevented. And these are the age groups in which those have been prevented. Roughly a third in children under the age of 5, about a quarter in people 65 and over, and another quarter in people 50 to 64 years of age. And then when we look at the deaths, again, this is an update from the last time we presented to you. Rather than about 2,000 deaths prevented over the first 2 years of the program, we believe now it's about 3,000 deaths prevented over the first 3 years of the program. And again, I mentioned this last time, we're fortunate that relatively smaller numbers of children actually die of invasive pneumococcal disease compared to adults. And that's why when you look at the distribution of the deaths prevented, most of those that are being prevented in adults who are not actually receiving the vaccine. So again, speaking to the herd protection of the vaccine. I mentioned the last time we presented to you in October, our case control study of vaccine effectiveness using PCV13. And I'll cut to the bottom line here because most of the other data that's shown here is very similar to what you've seen before. What's new from this table compared to what you saw before is that we now have individual level estimates of serotype-specific effectiveness. So the last time you saw these data, this number was about the same, and this number was about the same, the vaccine effectiveness of 1 or more doses against all IPD and then against all of the serotypes included in the vaccine. But when we look at the individual serotypes now, we can see a vaccine effectiveness of about 90% for serotype 19A, 100% for serotype 7F, and about 76% for serotype 3. All of these are statistically significant, so we're encouraged to see these data at this point. So in summary then, we're seeing reductions in IPD caused by those additional serotypes in PCV13 among all of the age groups, and we think that continues to encourage us of direct and indirect effects. We are seeing early evidence of increases in non-PCV13 serotypes in that one adult age group, 50 to 64-year-olds, that may be indicative of serotype replacement. That's an experience that was similar with PCV7. We began to see serotype replacement in adults relatively early on. Those increases in those non-PCV13 types are not overshadowing the reductions in the PCV13 types. And we now have preliminary evidence of serotype-specific effectiveness for the 3 most common PCV13 serotypes, and we have lots of additional analyses that we plan on doing. So, the permission of Dr. Tempte, I'll stop there and answer any questions you might have.
We are open for questions. Mike Dicker.
Could you go back to your slide 8 for a minute, please?
I'm sorry, which slide?
8. So I would just submit that those data say that you have got an increase in the lower 3 age groups. You simply don't have a sample size large enough to give you a confidence limit that doesn't cross null. But your point estimate for all 3 of those is a positive number. So I would caution you not to exclude the possibility that your point estimates are actually telling you the truth.
Oh, I'm sorry. I think I see what you're talking about now. When you said the lower 3 age groups, I thought you meant the youngest 3.
I meant physically the positive numbers in the right-hand column, 13, 26, and 7. Those are all positive point estimates. You said only the one in red differed, but that's not true. They all differ. 2 of them just don't differ.
Well, I think what I said was that it was only that one that was statistically significant, but I think your point's well taken.
If you had, I wouldn't be up here.
Other questions or clarification?
I have a question, Matt. In the non-vaccine type disease, is there a trend towards a specific type of illness, pneumonias or bacteremias, or?
You know, I thought what you were going to ask me is whether there was a tendency toward a particular serotype that was rising up.
I was also going to ask you that, but
okay.
You can answer both now.
Okay, so the answer to your first question is we haven't looked at it in that way yet to see whether there's a particular syndrome that's rising to the top. With respect to an individual serotype, what we're seeing right now are very, very small and not statistically significant increases in any individual serotype. So I would say there are at least 6 or 7 that look like maybe they're a little bit higher than they were before. But each of those increases is very, very small, and it's only when you add them all together that you get, again, this statistically significant change in that particular group.
Dr. Gorman.
This morning we heard some data that last year's influenza season was more severe than usual. Would that have had an impact on these numbers for this year?
Yeah, that's a great question. Thanks for asking. Ryan Gerke is a guy in our group who's been looking specifically at that issue. And it does seem that in some of our ABC's areas, there was at least a temporal relationship between influenza activity and increases in some of these non-vaccine types, but it wasn't consistent across all sites. And in fact, in some of the sites, there was no increase in non-vaccine types at all, and that wasn't necessarily associated with an absence of influenza. So there may be the beginning of a signal there, but I wouldn't call it a clear-cut message.
Thank you. Thank you much. And then I think we can have Dr. or Ms. Tomczyk come on up. And I've been forewarned that we will have time for some clarification questions after this, but for the bigger issue, I think we're going to wait until the last presentation.
Thank you. Good afternoon. Today I will be presenting on the results of the grade process evaluating the evidence for the 3-dose schedules of the 13-valent pneumococcal conjugate vaccine. So the policy question here is, should a 3-dose schedule of PCV13 be recommended for generally healthy infants in the U.S.? This presentation will address the grade process and the grade conclusions only. The next presentation will discuss the policy considerations. The grade process begins with defining the PICO, or the population, intervention, comparison, and outcome. The population of interest here for this policy question is children 2 to 15 months of age with no underlying medical conditions. The interventions and the comparisons were addressed in 2 different steps. In step 1, as seen here, we graded all evidence for each PCV schedule compared to no vaccine to assess the strength of evidence supporting each individual schedule, as if we were to consider policy decisions pre-PCV7. Thus, the intervention for step 1 included the currently used schedule of 4 doses of PCV13 given at 2, 4, 6, and 12 to 15 months, or 3+1 as we will refer to it, and 2 different 3-dose schedules given at 2, 4, and 6 months, or 3+0, and 2, 4, and 12 to 15 months, or 2+1. The comparison was no PCV13 or placebo. In step 2 of the grade process, we graded only studies with direct comparisons of schedules available within each study. This included the 3-dose schedules of 3+0 and 2+1 as compared to the currently used 4-dose schedule, or 3+1. We used a modified Delphi process to then rank the importance of possible outcomes. We conducted a survey of work group members and their colleagues, particularly practitioners and public health professionals, and the breakdown of the 48 respondents can be seen here. The respondents were then asked to rank a list of outcomes, 1 through 9, and the rankings were used by the work group to select critical or important outcomes, for which the grade review of evidence would be conducted. Outcomes rated 7 to 9 were determined critical for decision-making, according to the grade guidelines in step 1. Namely here, mortality, invasive pneumococcal disease, bacteremic and non-bacteremic pneumonia, serious adverse events, and indirect effects on IPD. Indirect effects ranked slowly below the critical threshold, but the work group determined that it was still critical. Pneumococcal meningitis and hospitalizations were also ranked as critical, but they were primarily included in the IPD outcome. Additional outcomes ranked, but not included because of low ranking, included office visits for pneumococcal disease, vaccine-type carriage, systemic adverse events, local reactions to the vaccine, and cost effectiveness. In step 2, any studies providing direct comparisons between schedules were included as determined by the work group, namely immunogenicity, or antibody response as a surrogate for IPD, lower respiratory tract infection, and acute otitis media. Next, I will present the grade framework for each step, following this outline. In step 1, I will present a summary of included studies and assess quality of evidence for each schedule and outcome. Randomized control trials, or RCTs, were considered first and selected for each schedule and outcome. When data from RCTs was not available, we then used observational studies. The data combined for all outcomes were used to determine the overall type of evidence for each schedule. Lastly, values and preferences were considered according to the a priori rankings of outcomes, and a judgment on recommendation category of each schedule was made. In step 2, we followed the same outline. It was organized according to the following comparisons between schedules: 3+0, 2 versus 3 primary doses, 2+1 versus 3+1, and the identified outcomes, including immunogenicity data as surrogates for IPD, lower respiratory tract infection, and acute otitis media. The final recommendation category was judged for each 3-dose schedule, 3+0 or 2+1, as compared to the 3+1 schedule. We will start with step 1 to present the grade of evidence for each schedule compared to no vaccine to assess the strength of evidence supporting each schedule. In step 1, I will start with the 3+1 schedule, an invasive pneumococcal disease and pneumonia. 4 RCTs were included in the US Navajo community, Finland, and Brazil. These studies evaluated the efficacy of PCV7 and PCV10. Vaccine efficacy for IPD ranged from 83 to 100%. Vaccine efficacy for X-ray confirmed pneumonia ranged from -8 to 20.5%. And we focused on chest X-ray confirmed pneumonia for all of the pneumonia outcome data listed here. For estimates of baseline disease incidence among the unvaccinated, we use pre-PCV incidence per 100,000 population of PCV13 type IPD, or all-cause pneumonia, among US children less than 2 years of age. We applied the pooled vaccine efficacy estimates for vaccine type IPD and pneumonia based on the studies presented on the previous slide to the baseline incidence to estimate the incidence among the vaccinated per 100,000 population. Using these data, we then calculated the absolute risk difference per person and the numbers needed to treat or vaccinate. On a 3+1 schedule, PCV had a 94% vaccine efficacy for IPD and 11% vaccine efficacy for pneumonia. The numbers needed to treat or vaccinate showed that 613 people needed to be vaccinated in order to prevent 1 case of IPD. Numbers needed to treat for pneumonia was not meaningful because the vaccine efficacy estimate was not statistically significant. To evaluate the indirect effects of PCV introduction on IPD at the population level, we used data from a pooled analysis of 21 surveillance datasets among countries with different PCV7 schedules. This graph shows the rate ratios of vaccine type IPD among adults during the 3rd year post-introduction of the vaccine in the US, Canada, Calgary, and the Netherlands, which have used the 3+1 schedule. The x-axis shows the adult age groups, and the y-axis shows the rate ratios. In spite of the differences between surveillance methods and the extent of catch-up, you can note that the effect estimates across all countries here are between 0.20 and 0.80, or 80 to 20% reduction in vaccine type IPD among adults, despite a few estimates that are not statistically significant. As you can see, PCV use in children has led to large indirect effects on IPD among adults of all age groups in countries using a 3+1 schedule. So that was the summary of the 3+1 data. I will now describe how we determined the evidence type for this 3+1 schedule data. In the grade process, this is done by first assigning an initial evidence type as follows. Type 1 is mainly RCTs, or overwhelming evidence from observational studies. Type 2 is RCTs with important limitations, or exceptionally strong evidence from observational studies. Type 3 is observational studies, or RCTs with notable limitations. And type 4 is clinical experience and observations, observational studies with important limitations, or RCTs with several major limitations. Next, that initial evidence type can be downgraded or upgraded according to the following pre-specified grade criteria, which includes the following: risk of bias, inconsistency, in directness, in precision, and other considerations such as the strength of association, dose response, or opposing plausible residual confounding or bias. Evidence can be downgraded, -1 or -2, when any of the grade criteria is serious or very serious. It can be upgraded, +1 or +2, if the strength of association is large or very large, and there is no apparent risk of bias. Thus, for the 3+1 schedule, the type of evidence was assessed according to the grade criteria as seen in the column headings. Both for IPD and pneumonia, you will note that we started with 3 RCTs, and there were no serious concerns, so the type of evidence for both outcomes was determined to be 1. For indirect effects, the 3 surveillance data sets were part of a pooled analysis, so the initial type of evidence was 3, and it was upgraded by 1 due to the strength of association and no apparent risk of bias for a final evidence type of 2. And the key point here to take away is that there is high quality evidence which shows that PCV 3+1 schedule is effective against IPD and pneumonia, and in addition has demonstrated large indirect effects. Next, I will present the evidence on a 3+0 PCV schedule. For invasive pneumococcal disease and pneumonia, 3 RCTs were included. These were conducted in South Africa, the Gambia, and the Philippines. These studies evaluated the efficacy of PCV9 and PCV11. Vaccine efficacy against IPD ranged from 77 to 83%. And for X-ray confirmed pneumonia, it ranged from 23 to 37%. As before, the data from included studies were used to obtain a pooled vaccine efficacy estimate for each outcome, which was then applied to the baseline pre-PCV7 incidence rates among US children less than 2 years of age for each outcome to calculate incidence among the vaccinated per 100,000 population. PCV had a 74% vaccine efficacy for IPD, and a 26% vaccine efficacy for pneumonia. The numbers needed to treat or vaccinate estimate showed that 779 people needed to be vaccinated in order to prevent 1 case of IPD, and 370 people need to be vaccinated in order to prevent 1 case of pneumonia. To evaluate the indirect effects of PCV introduction on IPD at the population level for 3+0, we used the same pooled analysis of 21 surveillance datasets. This included Australia, which has used the 3+0 schedule. The y-axis reflects the rate ratios for vaccine type IPD among adults during the 3rd year post-introduction, and the x-axis reflects the age groups. You can note that the effect estimates ranged between 0.20 and 0.50, or 50 to 80% reduction in IPD rates. The key point here is that the use of PCV on a 3+0 schedule among children in Australia also resulted in large reductions in IPD among adults of all age groups. We then used the abstracted data to determine the evidence type for 3+0 schedule. For both IPD, based on 2 RCTs, and pneumonia, based on 3 RCTs, there were no serious concerns for any criteria, so the type of evidence was determined to be 1. For indirect effects, based on surveillance data from 1 country using the 3+0 schedule, the initial evidence type was 3, but it was upgraded by 1 due to the strength of association and lack of bias for a final evidence type of 2. The key point here is that there is again high quality evidence that shows PCV 3+0 schedule is effective against IPD and pneumonia, and there are strong indirect effects demonstrated using this schedule. Next, I will present the evidence reviewing the 2+1 schedule. For the IPD outcome, we included one RCT conducted in Finland evaluating the efficacy of PCV10. Vaccine efficacy for IPD here was 92%. For the pneumonia outcome, we included 3 observational studies conducted in Canada, Italy, and Poland. Studies in Canada and Poland evaluated the impact of PCV7 introduction on chest X-ray confirmed pneumonia in children. The left graph shows the study in Quebec demonstrating a 72% reduction in lobar pneumonia before and after the introduction of PCV7 on a 2+1 schedule. The right graph shows the study in Poland, and there was also a reduction in X-ray confirmed pneumonia 4 years after PCV7 introduction. It was 65% in 0 to 1-year-olds. Lastly, the study in Italy was a large cohort study which showed a 65% vaccine efficacy estimate for X-ray confirmed pneumonia. As presented for 3+1 and 3+0, vaccine efficacy estimates for each outcome were applied to the baseline pre-PCV7 incidence of PCV13 type IPD and all-cause pneumonia among U.S. children less than 2 years of age to calculate incidence among the vaccinated per 100,000 population. PCV had a 96% vaccine efficacy against IPD, a 70% vaccine efficacy against pneumonia, and the numbers needed to treat or vaccinate estimate showed that 600 people need to be vaccinated in order to prevent 1 case of IPD, and 139 people need to be vaccinated in order to prevent 1 case of pneumonia. To evaluate the indirect effects of PCV introduction on IPD at the population level for 2+1, we again used the same pooled analysis of 21 surveillance datasets. This graph shows the rate ratios on the y-axis of vaccine-type IPD among adults during the 3rd year post-introduction, and age groups by country using the 2+1 schedule on the x-axis. You can note that the effect estimates across all countries are between 0.20 and 1.20, or 80% reduction to no change in all cases, despite a few estimates in Switzerland, Denmark, and Scotland that again were not statistically significant. Although there is some variability, you can still see that there is good evidence that the use of PCV on a 2+1 schedule leads to large reductions in IPD among adults. We then use the abstracted 2+1 data to determine the evidence type for the 2+1 schedule. For IPD, the evidence relies on 1 RCT, and there were no serious concerns for any criteria, so the type of evidence was 1. For pneumonia and indirect effects, observational studies were used, but the type of evidence was upgraded by 1 due to strength of association and a lack of bias for a final evidence type of 2. So again, the key point here is that there is high quality evidence, again which shows that PCV use on a 2+1 schedule is effective against IPD and pneumonia, and has strong indirect effects which have been observed in several countries using the 2+1 schedule. Next, I will briefly address the mortality outcome. I will not go through this table in detail because it is in your handout to look at more, but the takeaway point for mortality is that deaths due to IPD are low in high-income countries, including the US. None of the studies were powered to detect the impact of any schedule on this outcome, so we are unable to assess the impact of PCV schedules on mortality. The last outcome in step 1 was serious adverse events, which was assessed across all schedules and by dose when possible. 3 different types of evidence were used to grade this outcome. Evidence comparing PCV13 to no vaccine were not available. Thus, data comparing PCV13 to PCV7 as part of the PCV13 licensure application, and comparisons between PCV7 and the meningococcal C vaccine from one RCT conducted in the US were used. Additionally, an observational study was included to look at the incidence and timing of febrile seizures associated with PCV13 alone and when co-administered with the influenza vaccine. Using the data from the Prevnar licensure application, this table first shows the comparison of incidence of deaths and overall serious adverse events between PCV13 and PCV7 groups. There were 3 deaths in the PCV13 group and 1 death in the PCV7 group. In the PCV13 group, the date of death included 3 days post-dose 1, 14 days post-dose 2, and 76 days post-dose 3. In the PCV7 group, the date of death included 13 days post-dose 1. For overall serious adverse events, there were small differences between the 2 groups, as you will see here, and investigators believed that these serious adverse events were related to the vaccine. This table compares the incidence of death in the PCV7 group as compared to the control group. In the PCV7 group, there were 4 deaths, or 0.2 cases, per 1,000 children. In the control group, there were 8 deaths, or 0.4 cases per 1,000 children, although investigators reported that these deaths were not related to the vaccine. We also reviewed a published study using the Vaccine Safety Datalink Project data, which evaluated the risk of febrile seizures in children following a co-administration of the influenza vaccine and PCV13. The bottom brown line shows risk differences for the influenza vaccine only by months of age. The middle green line shows PCV13 only, and the top blue line shows PCV13 and the influenza vaccine administered together. Risk difference estimates varied by age due to the varying baseline risk for seizures in young children, with the highest estimates occurring at 16 months, around the time when the PCV booster is administered. The risk difference peaked at 13.7 per 100,000 doses for PCV13 without the co-administration of the influenza vaccine, and 44.9 per 100,000 doses for both the influenza vaccine and PCV13. The lowest estimates occurred at 59 months. Overall, there are many unique vaccine combinations, so it may be difficult to estimate the risk for each combination due to lack of statistical power. Additional analyses looking into different vaccine combinations and comparing risk within different age groups is forthcoming and will be presented to the committee at a future date. Next, we determined the evidence type for the serious adverse events. We included 14 RCTs for an evidence type 1. However, due to indirect comparisons, where we compared PCV13 to PCV7 and PCV7 to a control vaccine, we downgraded the evidence type by 1 for a final evidence type of 2. The key point here is that the PCV appears to be safe across all schedules. Next, we combined all of the evidence types just presented per outcome for each schedule to assess overall evidence type by schedule. The lowest evidence quality from critical outcomes assessed for each schedule was used. Thus, each schedule is supported by a type 2 or strong evidence. We next considered prevailing values and preferences. Work group members determined that the values and preferences were high for IPD, pneumonia, and serious adverse events, but of relatively lower value for indirect effects. Lastly, we put our assessment data together to make a judgment of the recommendation category for each schedule in step 1. We asked the work group members to respond to the following 4 questions. Is the evidence quality low? The work group determined that the evidence quality supporting each schedule was high. Are the net benefits low, or is there uncertainty about the balance of benefits versus harm? The work group determined that there was no uncertainty about each schedule providing protection against critical outcomes. Is there variability or uncertainty in which outcomes are important to prevent? The work group had reached consensus on which outcomes are important. And is there uncertainty about whether the net benefits are worth the costs? We determined that the intervention was cost-effective. Cost-effectiveness studies for PCV have been conducted and published as previously presented to this committee in October. And for the sake of time, we did not present data again here. These answers indicate that each schedule is supported by a Category A recommendation, which is a recommendation for which the desirable effects clearly outweigh the undesirable effects. Overall, the grade process suggests that if we had to make policy decisions to recommend PCV on either schedule for the first time, the data would support the use of any of these schedules. I will now present step 2 of the grade process, focusing on the studies with direct schedule comparisons only. Most of the direct schedule comparisons were obtained from immunogenicity studies. We abstracted data on IgG antibody concentrations and the proportion achieving a response of concentrations of greater than or equal to 0.35 micrograms per milliliter following the primary series of PCV or following a booster dose for each schedule. A threshold of 0.35 is a reference point which was developed for antibody comparisons in infant vaccine schedules to support an IPD indication. Comparisons between schedules were also made by looking at the risk ratios comparing the proportion greater than or equal to 0.35 between groups and the ratio comparing geometric mean concentrations in each group. For step 2, immunogenicity RCTs with direct schedule comparisons included those conducted in Israel, the UK, one across Europe, in Fiji, in Iceland, and in the Gambia. 4 studies had comparisons between 2+1 or 3+0 versus 3+1, and 2 studies had comparisons between 2 versus 3 primary doses. PCV 7, 9, and 10 were evaluated in these studies. The first table presents the comparison of immunogenicity data for 3+0 versus 3+1, and it shows the proportions of antibody levels greater than or equal to 0.35 for each group in the middle 2 columns, and the risk ratio comparing the percentage above this threshold and GMC ratios for 3+0 and 3+1 in the last 2 columns. Antibody levels for the 3+0 schedule were assessed post-primary, or at approximately 7 months, and for 3+1 were assessed post-booster at approximately 13 months. 3 serotypes, 6B, 23F, and 1, had significantly lower proportions above the 0.35 threshold in the 3+0 schedule as compared to 3+1. For all serotypes, GMCs were significantly lower for the 3+0 schedule. These results highlight a strong boosting effect observed when the last dose is given in the 2nd year of life following a primary series. However, I would like to note that in the middle 2 columns in both groups, they had high proportions above the 0.35 cutoff. The second table presents similar comparisons for 2 versus 3 primary doses. The response in each group was measured approximately 1 month post last dose. No serotypes showed differences by percentage above the threshold. And 2 serotypes, 6B and 23F, had significantly lower GMCs for 2 compared to 3 doses. However, again, both groups had high proportions above this 0.35 cutoff. The last table of immunogenicity outcome data shows comparisons for 2+1 versus 3+1. Only one serotype, 6B, had a significantly lower protection above 0.35 cutoff for the 2+1 schedule as compared to 3+1. And 2 serotypes, 6B and 18C, had significantly lower GMC ratios. However, again, both groups had high proportions above this 0.35 cutoff. So we realize this is a lot of immunogenicity data to digest. So I promise we're nearing the end. But to help you out more, we thought we would try to describe some of the key points. The following can be summarized for immunogenicity. The proportions greater than or equal to 0.35 are high for schedules with 3 and 2 dose primary series. Post-primary, the 3-dose schedule appears to be better than the 2-dose schedule for some serotypes, according to the GMC ratio data. In the second year of life, pre-booster and post-booster dose, there were small but significant differences for some serotypes, according to the GMC ratio data. The differences appear to be more pronounced after the primary series and when comparing GMC values or ratios rather than proportions greater than or equal to 0.35. However, we also wanted to draw your attention to some caveats with this data that need to be considered when interpreting. Regarding a cutoff of 0.35 micrograms per milliliter, the World Health Organization had determined this cutoff value that correlated with protection against IPD through various stages. First, the results of a US trial, which showed a 0.2 cutoff post-dose 3, correlated with 97.3% vaccine efficacy against IPD. Later, data from 2 RCTs were added. One PCV7 trial among American Indians, which showed a cutoff value of 1.0, which correlated with 76.8% vaccine efficacy, and one PCV9 trial in South African infants, which showed a cutoff value of 0.68, which correlated with 90% vaccine efficacy. After adding data for these 3 trials, the aggregate cutoff was determined and raised to 0.35. So what this data tells us is that children at a higher risk for pneumococcal disease may require higher antibody levels to achieve an equivalent protective efficacy. But the key point for the US population is that the cutoff for IPD of 0.35 micrograms per milliliter is likely higher than necessary for a US population of generally healthy infants. Overall, the GMC cutoff of 0.35 should be interpreted with caution. It was developed as an aggregate cutoff for all serotypes combined, and its clinical significance is not established for individual serotypes, post-booster measurements of antibody levels, and for non-IPD endpoints. In addition, GMC ratios were presented to compare the schedules should also be interpreted with caution, because they do not take into account absolute values for the antibody levels of the groups compared. For example, 2 versus 4 micrograms per milliliter and 0.35 versus 0.7 have the same GMC ratios. So the key point is that it's important to interpret the differences with caution and look at both the percent greater than or equal to 0.35 and the absolute values. Thus, for all immunogenicity comparisons, the type of evidence is 1, because we started with RCTs and there were no serious concerns noted across criteria. We also identified 2 observational studies with direct schedule comparisons in the US using PCV7 on lower respiratory tract infection, or LRTI, and acute otitis media, or AOM. Although it should be noted that AOM was not ranked as one of the critical outcomes in step 1. The first observational study, using a propensity score matched case cohort design in the US, evaluated the rate of hospitalizations and ambulatory visits for pneumonia in a 2002 birth cohort, comparing 2 versus 3 primary doses. Comparisons between schedules with 2 and 3 primary dose series before booster are shown on the left graph and after booster on the right graph. The y-axis shows the LRTI-related hospital admissions, and the x-axis shows the follow-up months. The top solid black line represents schedules with 2 doses in the primary series, and the bottom dotted line represents 3 doses in the primary series. And this study found that there was a statistically significant rate difference of 7.8 cases per 1,000 children, or fewer pneumonia-related admissions in those who received 3 doses versus 2 doses. However, this difference disappeared after the booster dose was administered. This table shows the data from the same study, but what was repeated for the 2003 birth cohort. Post-primary, 3+1 had a greater incidence as compared to 2+1, but the absolute rate difference was not statistically significant. Post-booster, 3+1 had a lower incidence as compared to 2+1, but again, the absolute rate difference was not statistically significant. It is difficult to interpret these results, given that pre-booster, the 2-dose primary series had lower rates, and post-booster, the 3-dose primary series had lower rates. And as mentioned, none of the differences were statistically significant. The authors of the paper concluded that there were no differences observed between schedules for this 2003 cohort. They hypothesized that by 2003, or 3 years after introduction of PCV7, herd effects had lessened the difference in the risk between the 2 groups. The second observational study, comparing the incidence of acute otitis media in children born in 2002 who received 2 or 3 doses in the primary PCV7 series using propensity score match data from an insurance claims database. The study assessed acute otitis media rates after completion of the primary series and before the booster dose, which is the figure on the left, and after the booster dose, which is the figure on the right, until 4 years of age. The results showed that the pre-booster dose incidence rates were 0.38 per person for children receiving 2 doses and 0.35 per person for children receiving 3 doses, but these rates were not statistically different. Post-booster incidence rates were also not statistically significantly different between the groups. The key point here is that there were not statistically significant differences between schedules with 2 versus 3 doses in the primary series pre or post-booster. The direct comparisons of clinical pneumonia-related hospitalizations and acute otitis media were observational studies. So the initial evidence type of both started as 3 and remained this type because no grade criteria were applied for upgrading or downgrading. The key point here is that there's unfortunately limited studies with direct head-to-head comparisons and clinical endpoints. Using the evidence type tables presented by schedule and by outcome, we then determine the overall evidence type for each schedule comparison. The lowest evidence quality from critical outcomes assessed for each schedule comparison was used. Thus, all schedule comparisons had a type 3 evidence. The work group members determined that the values and preferences were high for pneumonia, but of relatively lower value for acute otitis media and immunogenicity. Immunogenicity data was ranked as relatively lower value because the clinical significance of this surrogate data is not established for non-IPD outcomes, post-booster dose, or individual serotypes. Lastly, we put our assessment data together to make a judgment of recommendation category for each schedule. We asked the work group members to respond to the following 4 questions. Is the evidence quality low? It was determined that the evidence quality supporting each 3-dose schedule compared to a 4-dose schedule was low because limited head-to-head comparisons were available, and the available immunogenicity data were used as surrogates for IPD, but not for other critical outcomes. Are the net benefits low, or is there uncertainty about the balance versus benefits and harm? The work group determined that there was some uncertainty about the balance given the observed differences for some serotypes in antibody response and the clinical relevance of these differences. Is there variability or uncertainty in what outcomes are important to present? The work group reached a consensus on which outcomes were important to prevent. Lastly, is there uncertainty about whether the net benefits are worth the costs? As mentioned earlier, cost-effectiveness analysis comparing the 2+1 schedule to 3+1 was presented last October to this committee. The study was published, and based on the results, it was determined that the 3+1 schedule, when compared to the 2+1, was less cost-effective. And so to conclude the findings of the grade review, in step 1, there was strong evidence supporting each individual schedule compared to no vaccine. In step 2, there was more limited evidence with few studies showing direct schedule comparisons. Thus, the grade process supports a Category B recommendation for each 3-dose PCV schedule, 2+1 and 3+0 as compared to 3+1, or the 4-dose schedule, meaning a recommendation for which the desirable consequences probably outweigh the undesirable outcomes. The next presentation will incorporate these grade conclusions along with additional data and considerations and present the work group conclusions thus far. And I just want to acknowledge all of the pneumococcal work group for all of the hard work that went into the grade process. And thank you for sticking with us because we realize it's a lot of data as well. And I thank you. I think I have a few minutes for questions as well.
Thanks for a very complete discussion, kind of looking at a very nuanced approach here. Dr. Harrison, do you have a...
Yeah, in terms of antibody persistence, you showed data, I believe, through 13 months for some of the schedules, but are there longer-term persistence data for all 3 schedules, comparing the 3?
Correct me if I'm wrong, but we did not find any of this data. Yeah, and the measurements that we did show was limited to what was available in the studies.
I'm thinking of data from the UK with the meningococcal C conjugate vaccine. The accelerated 3+0 schedule had very limited persistence of antibody, and efficacy went away after 1 year.
I don't know, did the SMEs want to comment on that study in particular?
I guess we would just say it's a completely different vaccine. And you're right, if I'm not mistaken, that accelerated schedule is 2, 3, 4 months, and what we're talking about here is really more like a 2, 4, 12 or a 2, 4, 6. I think that probably makes an important difference.
Dr. Vasquez.
I have a question regarding the importance of the timing in between vaccines. The schedules that you're proposing would be 2, 4, and then the booster, or just 2, 4, 6. And I'm thinking, when you think about grade, I mean, I totally understand randomized clinical trials give you best information because they are experimental, but effectiveness tends to be lower than efficacy. And in the trials that you're showing, these intervals were adhered to there were controlled studies. And I'm thinking about sort of real world where if we go to the 2-1 schedule, somebody might get a 2-month vaccine, not get another one until they're 10 months or 9 months, and then come back potentially for their booster. And I'm thinking if that initial interval, short interval, is important, we won't know whether these labs or out of the recommended interval work as well or not.
Yeah, I think that's a really good point, and we didn't address the interval in the grade process in particular. Mm-hmm. Cindy?
Dr. Gorman?
Or Doctor?
Thank you for that tour de force through the data. And I hate to pick because I didn't understand something on slides 24 and 25. Yep. If you could go back to those.
Mm-hmm. All right, it goes a bit slow. Thank you.
So on slide 24, your controlled incidence is the United States incidence and not the incidence of those diseases in those countries. Is that correct?
Correct. So it's incidence among U.S. children less than 2 years of age pre-PCV7.
So if the incidence of these diseases in these countries where these studies were done was higher, the number needed to treat might have well have fallen.
Yeah, correct.
If you can go to the next slide, please.
25.
25. Mm-hmm. So you have a rate ratio. Now, is that the same rate again as the United States rate, or were those the rates specific for those countries both before and after the introduction of the vaccines?
These are specific to these countries because they're from a completely separate study of a pooled analysis of specific country surveillance data sets.
Thank you.
Mm-hmm.
Dr. Dusky?
My question comes along slide 48. You had said that there was a statistically significant increase in hospital admissions for lower tract infections during the primary series until the booster is done. Is that correct?
Right, pre-booster.
And you expect that to hold up now that some herd immunity is around?
I don't know. Did the SMEs want to comment on that as well?
If you want to just go to your next slide.
Yeah.
I think that'll help.
This one?
Yeah, so as Sarah mentioned, in this particular study, in the 2003 birth cohort, that association did not write. And so, and at least the interpretation of the authors, and I think other people who've read this have interpreted it to mean that once the herd effects kick in, then those serotypes are less available to cause disease, and so the differences between schedules are smaller.
Mm-hmm.
Dr. Brady?
Yeah, I have two things. First of all, I mean, I think the grade system works well for grading the evidence, but sometimes it doesn't help you with the conclusions. And when you look at the invasive pneumococcal disease with the 3+0, the vaccine efficacy was only 74%, and the 2+1 and 3+1 were in the mid-90s. I don't think that you can say that they're equivalent. I think that if you're looking at does 3+0 prevent pneumococcal disease, yes. Is it equivalent to the other ones? No. The other question I have is most of these studies were done now, the 3+0 were done in African countries. We've done a really nice job in the United States of eliminating the difference or disparity in pneumococcal disease in African American children. And I would hate to find that we actually do need higher levels of antibody to protect African American children. And if we went to a schedule that was either 2+1 or 3.0, and we now return to having a disparity, I would be very uncomfortable with that. So I think that's one of the issues that needs to be addressed, because when you look at most of the countries, they don't have the level of African American children. And if you notice from the Native American population, they needed a much higher level to get vaccine efficacy. And I don't know if we know what it is in African Americans, but I would be very uncomfortable if we were to see a change.
Yeah, point taken. Thank you.
Yes, Cindy.
Yeah, if I could just throw in one caveat around that, and it also speaks to the point about the intervals. The trials in Africa were done on schedules of 6, 10, and 14 weeks, so there's only 4 weeks in between. And we know with pneumococcal vaccine, you actually get a better response if you spread out the doses to at least 2 months. 2 months is better than 1 month. I think the balance we need to strike here, though, is we don't want to spread it out too far because we don't think a single dose gives you enough protection. So it's just one possible difference that the African data look different than the trials, say, in Kaiser.
Any additional questions for clarification?